All right. Hello and welcome, everyone. This is Caleb from TASC at the National Rural Health Resource Center. Today is Thursday, November 5th, and this is our November TASC 90 webinar. We are here today to talk about integration of rural health clinics and hospitals. And our speaker today is Tony Ann Richards, CEO of the Healthcare Collaborative of Rural Missouri, HCC. The collaborative is the hub of rural network development in West Central Missouri. Tony Ann is responsible for leadership development and implementation of responsive and innovative programs in the region. The Healthcare Collaborative is a leader in vertically integrated healthcare networks, which focus on providing quality care to people in their local communities. The Rural Health Network emerged from an obscure two-person nonprofit organization to an organization close to 100 employees and 8,000 patients through the community healthcare center model. Tony Ann serves in leadership positions through the Missouri Rural Health Association, National Rural Health Association, Board of Trustees, and Rural Health Congress, Missouri Primary Care Association, and is a 2014 graduate of the University of Kansas Medical Center Health Center Executive Program Fellowship. Tony Ann is married to Pat and who's the head football coach at Oak Grove High School and has a teenage daughter, Grace. So join me, please, in welcoming Tony Ann when we get to that part of our agenda. But first, I will provide a few updates from the TASC team, and then we will invite Tori Leach from the federal office, Carrie Conejo, also from the federal office, Carla Wang from Stratus, Megan Lahr from the University of Minnesota and the Flex Monitoring team to provide program updates. As far as updates for TASC, we have a webinar on November 23rd focused on evaluation. We will be offering coaching calls with subject matter expert Rochelle Spinarski following that webinar. So it's a great opportunity to utilize the data, your data as Flex coordinators to tell your story when finalizing your end of year reports that are due at the end of the month. Recently, the COVID-19 funding sources impacting rural providers has been updated. TASC, in coordination with the Federal Office of Rural Health Policy, is excited to provide the update. And please let us know that was updated, I believe, just a couple days ago. The Flex Fundamentals Guide has been updated and will be sent out via mail as well as email the end of the month. So be on the lookout for that, as well as the SHIP Transparency Guide was released yesterday. If you have any questions regarding the SHIP Transparency Guide that was released yesterday, please do reach out to ship@ruralcenter.org with any questions, or if you have any questions, the normal email addresses, phone calls will suffice. Those are all of the TASC updates I have. Tori, are you on?
Hi, everyone. I'm here. Just a couple of updates from the Flex program side from the Federal Office of Rural Health Policy. Thank you to everyone who submitted their performance improvement measurement system reports. Your project officer should be in touch soon to see if there are any changes that are required of that submission. As Caleb already mentioned, you have your Flex FY 2019 end of year report due on November 30th. For those of you who are awarded the EMS supplement, that should be 8 of the Flex programs, you also have an end of year report due on November 29th. Feel free to reach out to me or any of your Flex project officers for any questions or concerns. I'll turn it over to Carrie.
Carrie Conejo from the federal office, are you there for the regulatory update? While we wait for Carrie to get unmuted, I would like to offer anybody the opportunity to ask Tori or myself any questions. Right.
Hey, this is Carrie. I can jump in if we're all ready.
We are ready for you. Thank you.
Thank you. Sorry. So I just have some updates to rules and guidance that I'll share with you, along with some new resources I just wanted to point your attention to as well. The first is a Medicare Advantage notice, part 2 of this notice with comments due November 30th. Basically, It's for calendar year 2022, and it includes estimates of changes in payments to MA plans and requests for input on future quality measures and concepts for the Medicare Advantage and prescription drug plan star rating system. CMS also issued a final rule on price transparency for private insurance. And this is actually HHS, Department of Labor, and Department of Treasury together, requiring individual and group health insurers by 2023 to offer online tools for consumers to help estimate how much they'll have to pay in terms of their out-of-pocket costs for health care before they receive care. The rule also requires that by 2022, insurers publicly display their negotiated rates for in-network providers, their historical payments to out-of-network providers, and their in-network negotiated rates. CMS also recently finalized the calendar year 2021 payment rules for home health. So it includes an overall payment increase for rural areas. Other policy updates include remote patient monitoring and other policies related to the home infusion therapy benefit. And CMS is also finalizing the OMB delineations for statistical areas that change the status of several counties between rural and urban. So that is being finalized as well. But CMS included a transition period to mitigate any potential decreases in payments. Related to COVID, recently, over the past couple of months, CMS had continued to issue more interim final rules on COVID flexibilities. The most recent was issued on October 28th. This was the fourth interim final rule of comment period. Highlights of interest include some vaccine-related provisions, flexibility for states maintaining Medicaid enrollment during the COVID-19 public health emergency, enhanced Medicare payments for new COVID-19 treatments, and price transparency requirements for COVID-19 tests. And comments are due 60 days after the date of display in the Federal Register. The third interim final rule, CMS issued that on September 2nd, and that included the new requirements in the hospital and critical access hospital conditions of participation for daily reporting of COVID-19 data. CMS also recently had released guidance for hospitals on the COVID-19 data reporting requirement applying to hospitals and CAUS. So hospitals and CAUS must report daily to the federal government or state if they receive a written release from the state, and failure to do so has some enforcement actions associated with it. CMS has also recently published some data looking at individual hospitals. It's also available online and was included in a recent version of our announcements. Just another item related to COVID, a couple items. There have been some updated reporting requirements for the Provider Relief Fund, but it basically updates guidance that was provided in July, and it lists the data elements that the PRF recipients must report for the calendar years 2019 and 2020. And then there's also new CMS guidance on repayment terms for the Medicare accelerated and advanced payments. Just some other non-COVID-related items. I'll go through this quickly. The deadline for critical access hospital meaningful use hardship exception applications is November 30th. So CMS requires that all CAUS use 2015 edition certified electronic health record technology to meet the requirements of the promoting interoperability programs. But if a CAUS can provide proof that meeting the requirement results in significant hardship, then they can apply for an exception, but that's valid for only 1 year. Also, HRSA has recently requested comments on proposed Data 2000 training payment application process. So soon HRSA will be able to reimburse FQHCs and RHCs for training costs of physicians and practitioners to obtain waivers under the Drug Addiction and Treatment Act of 2000. And these waivers allow eligible physicians to treat opioid dependency in settings other than an official opioid treatment program. And comments for that are due on December 7th. And lastly, CMS recently finalized 2 new specialty payment care models. The first is the radiation oncology model that creates a bundled payment system for providers of radiotherapy treatment, and the other is the end-stage renal disease treatment choices model. as part of the federal Advancing Kidney Health Initiative, and it adjusts payments to ESRD facilities based on the availability of home dialysis programs and the reduction of kidney transplant wait times. Both of the start dates for these models, they were set to begin on January 1st, 2021. The ESRD model is still slated to start on that date, but CMS, in response to stakeholder feedback, delayed the start date of the radiation oncology model to July 1st. And just some resources I wanted to point you to before I turn the presentation over. But CMS recently released frequently asked questions on the chart model that you can access on the chart website. There's also a rural crosswalk available to help rural facilities like critical access hospitals, rural health clinics, and FQHCs understand which of the different COVID waivers and flexibilities apply to their facilities. And CMS also had started a new website on hospital price transparency to help hospitals and CAUs with the requirements that go into place on January 1st. So I'll just stop there and see if anybody has any questions.
Thank you very much. Anyone please do unmute or put any questions you have in the chat box for Carrie Conejo from the Federal Office of Rural Health Policy. There was a little bad call quality there, Carrie, so I will encourage anyone to log into the Flex forum where we do have the complete policy regulatory updates in the Flex forum. If you have any questions, please do let us know. All right, hearing or seeing no questions, I will ask if Carla Wang from Stratus Health and Arkita is on.
Yes, I am. Can you hear me?
I can. Howdy.
All right. Hello, everyone. So my first update isn't truly about Arkita, but I'm going to share it with this group anyway. I think most of you or many of you are aware that my colleague Sarah Brinkman has been expecting a little one, and that little one arrived yesterday. So she now has a second little boy. His name is Asher Bernard, and mom baby are doing well, and big brother Wally is very, very proud. So the program related update to that is that Sarah is now on leave for the next couple of months. So I know that she has frequently been the face and the name and the voice that you hear from Arkita and about MBQIP updates. So you're going to be hearing from the rest of us a bit more for the next couple of months. So I actually sent out MBQIP monthly today. So if you've been looking for an email from Sarah with the November MBQIP monthly, you'll need to look for one from me. And we'll continue to process updates. So feel free to reach out to either Robin Carlson, Laura Grangart Johnson, or I in Sarah's absence, or you can always reach out to the TASC team and they get us any questions and information that is needed. So that's probably our major update, but a couple other things to note. There is on November 18th, the CDC and FRHP are co-hosting an antibiotic stewardship webinar that is focused on critical access hospitals. It just happens that National Rural Health Day falls the same week as Antibiotic Stewardship Awareness Week from the CDC. So they, for the last couple of years, have been doing some joint programming there. There's information in that in the MBQIP monthly and the announcement that I sent out earlier this afternoon. So encourage you to register for that or encourage your hospitals to participate in that. We've been working quite a bit with Megan, who's next, and Natalia and the FRHP team on the transition for the MBQIP data reports. We know many of you were on the open office hours discussion last week for that. We will also be having continued discussion about that new structure and format and resources on the MBQIP virtual knowledge group. We did shift the date on that. Hopefully you saw the announcement for that a couple of weeks ago. We didn't want to conflict with any National Rural Health Day events on the third Thursday when we typically hold those. So we have shifted that date to December 3rd, and I'll be sending more information out, an agenda for that in another week or two. So we'll focus on the MBQIP data reports. And we're also going to be, as we get through the process of getting all of that process transitioned, we have several resources that will be getting updated to align with the new reports and the new report format. So I think that is it for updates on my end.
Great, thank you, Carla. Any questions for Carla and the Arkita team or Stratus? Hearing none, I will offer congratulations from us here at TASC for Sarah. We're all very excited and happy for her. Megan Lahr from the University of Minnesota and the Flex Monitoring team, are you on?
I am.
Howdy.
So some updates from the Flex Monitoring team. In the past month or so, we've released several new products, including a policy brief that a lot of you contributed to, but it's about supporting cause during the COVID-19 pandemic. And that's a summary of results of the survey of state Flex coordinators, as well as a briefing paper on our website that is on the implementation of Flex EMS supplemental funding projects from year one activities. So check those out. Speaking of our website, the Flex Monitoring team, we just this fall had an overhaul of our website that launched. And so same web address, flexmonitoring.org, but we'd encourage you all to take a look, take a brief tour of the site, see what's on there. A new section that we have is called State Profiles. And that section has all of the state data reports. And so you can look through, click on your state, go through select financial, quality, or community reports and see everything related to your state, as well as other products that mention your state in that section. And obviously our publication sections has all of our publications as well. And so feel free to take a look at the site and let us know if you have any questions, but we just wanted to highlight that. Our Compass data query tool has new updated data for the community coming out. That should be up, hopefully, we were hoping this week, but for sure by next week. So we're excited about that. And then we're well on our way into working on our new projects for this year. Those projects include projects that focus on identifying potential new measures for MBQIP, evaluating the EMS supplemental grants, that's a continuing project, examining the effect of system affiliation on CAH financial performance, looking at lessons learned from states and federal demonstration initiatives to support rural hospitals, and assessing the strategic response to COVID-19 in critical access hospitals. And we just want to say thank you for the state Flex programs who helped us be able to reach out to cause in 8 different states. We just wrapped up the data collection part of that COVID survey, and we were able to hear back from 70% of the cause, over 150 cause filled out our survey. And so we're really excited about that. And then, as Carla mentioned, on the quality side, we are working on the MBQIP quarterly reports. And so, again, if you have feedback on those, we're always open to that as well. So those are all of my updates. If there are any questions or anything else.
All right, thank you, Megan, the Flex Monitoring team. Any questions for Megan and the Flex Monitoring team? All right, hearing none, I will ask if Tony Ann is still on, and we can pull up her slides. I'm really excited to hear from Tony Ann and talk about some of the integration of primary care as well as the networking and collaborative efforts that she's participating in down in Missouri. This is really neat stuff.
Yes, I am. Whoops, I knew that would happen. I am here. Can you hear me?
I can.
Okay, let me see if I can figure out how to send this back. You have to love dual screens.
Right?
Okay, now can you see it?
We can.
All right.
So right now we're in there we go. We can see your notes as well as your next slide.
Okay, how's that?
So now we can see most of the application.
Oh, shoot.
The presentation mode.
It's probably on a different screen. Try to share
Yeah.
the screen that actually has it.
There you go. Thank you, whoever said that. Is that better?
Hey, there we go.
All right, so go ahead and get started. I am pretty sure I cannot figure out how to go back to that first slide without making everybody seasick on the screen. So I'll just start with this slide here, slide 2. My name is Tony Ann Richard. I'm the CEO of the Healthcare Collaborative of Rural Missouri. We are an organization that was founded on really grassroots efforts to develop public health response programs in the early 2000s. And so when we first started, we were an initiative out of the state public health department in conjunction with our local public health department, and really focused on things like walking trails, school food, school health and wellness programs, and then working with the aging population, just to keep people in a place where they could live at home a little bit longer, and access resources that were local in their community. So we've had several years of strategic planning. This is where this screen that you're looking at now is really focused on where we ended up after we opened the federally qualified health centers, and I'll talk about that in just a minute. But really making sure that we were focusing on cultivating partnerships. HCC, our original founding board, had the hospital CEO on it, the critical access hospital CEO, the CEO of the federally qualified health center in our community, the local public health department, and the community mental health center, along with the District 3 Area Agency on Aging, and some other community leaders within our service area. And so we became that organization that just had to know kind of a little bit about everything that was going on. And our primary goal at that time was to secure new funding for public health programs, but also work on marrying people up in terms of programs and products and services, and take a look at where the gaps are in our community and how we could help address them through the network, to help leverage the capacity within each individual organization. So we did that through market and strategy driven programs, including the addition of school-based health clinics. We launched a health transportation volunteer driver program and community innovation. We really encouraged people to think outside of the box. We became the organization that was able and willing to try new things. I think one of the greatest things about our organization is we have never been afraid of failure. We don't shy away from hard projects because of failure. We try to learn from everything that we do, and to put that risk out there especially for organizations that are not able to take on as much risk. Being fiscally responsible, I think it's so interesting always to hear the stories of CEOs like myself that were early on in the foundation of the organization. We started out with 1.5 employees. We had about $100,000 in committed grant funds. And my board at the time said, if we're here to support you, we want this to work. But we need a leader in here, an entrepreneurial leader that can develop programs and services, and we need to be able to do our day job. So fast forward 13 years later, we have about a $9.5 million budget and 5 federally qualified health centers, several school-based sites, and a couple of mobile units. And so really responding to that need in the community was important, but managing that fiscally was really challenging. We had, times when we weren't counting days cash on hand, we were counting hours cash on hand. So where that risk really paid off was we kept grinding at that, and we saw a lot of success and follow from that. We also spent a lot of time recruiting members to our network. We didn't want to focus, we're a vertically integrated network, and so we didn't want to focus on only healthcare organizations, but we really wanted to focus on the social aspect of services. And I always tell Terry Hill that HCC was doing social determinants of health work before it was a cool thing to do. So we started out working with food pantries, local food banks, and bringing harvesters into place, making sure that seniors had healthy food. We were working on housing initiatives and clothing initiatives, and mental health well-being in the early 2000s. We also wanted to make sure that all of our patient and community engagement through marketing and outreach is that people could actually see us in the community. We had we had a physical presence. We were sponsoring things like the high school basketball team. We were out there. We were members of the Rotary, attended a lot of community meetings and just building those relationships. And one of the things that we really focused on was finding out what were the needs of the organizations in our community. And, you know, a lot of people were really comfortable talking about a place that we could help. And then quality workforce, like all of you, clinic staff retention and recruitment is hard no matter what area of discipline you're in. Safetynet staff retention and recruitment is difficult. There's some things that have made it a lot easier for us. Programs like the National Health Service Corps and some loan repayment programs, but it was more about finding the right people to fit the culture of not only our organization, but also the patients that we served. And so some examples are, we had a phenomenal physician who just did not like the population, the constant needs of the patients that we were serving. And so while he was a great physician, it just wasn't a good fit for the organization. So trying to find the right focus on doing that. We implemented some leadership programs and improved our way that we promoted positions, and also improved the way that we participated and engaged in interviews with people. Grounded in competent and valued healthcare practices. We really wanted to be a leader in that space where we could have good conversations with people. We wanted to be constantly learning from our peers and from our state and local and federal partners. And so again, not to keep repeating myself, but building those relationships was really important. One of the things that we had to do early on was figure out what we didn't know. So much vulnerability in an organization is that leadership can't admit the things that they don't understand or the things that make them uncomfortable. And so getting out there and finding some experts, bringing them on one way or another to help teach us, and then taking that information and creating our own space was really important. And then guided by rural health leadership standards, we didn't want to just be a grantee of FORHP and do our network activities and then wait for the next grant to come along. It was really important to us that we spent some time figuring out what sustainable organizations were doing, what were sustainable networks doing. And the biggest thing that we found is that they were constantly raising their standards. And so being in tune to national, regional, and local initiatives for the network was really important to help fill in some gaps for people. So now we're going to try the next slide here. This is just a snapshot of, and I'm so sorry, there's a train going to drive by my office. Nothing like true rural community right here. We have a train that drives by about 6 times a day. The history program and impact slide is just a snapshot of our timeline and some of the things that we did. You'll see in there, we did some diabetes and depression programming in early 2012. In June of 2013 is when we opened our federally qualified health center. That came about because our chairman of our board at the time was a critical access hospital CEO. They had 2 rural health clinics that were not they were not financially successful under the rural health clinic reimbursement model, particularly because of the overhead allocation of the hospital and different issues with the cost report. But he knew that being part of our board, that there was a huge opportunity to sustain the services in those 2 communities, retain the providers in those communities, and ensure that the patients continued to get care. So they actually donated those 2 clinics. And when I say donated, they donated one building and the blue sky to both of those practices. We assumed responsibility of their patients. Simultaneously, we were applying for FQHC status. We actually were denied after we had opened the rural health clinic under our model, and a few months later we were funded as an FQHC. But those months of a nonprofit rural health clinic standalone, the challenges that we faced will forever be the foundation of how we make decisions going forward, and how we continue to respond to the community. So through that partnership with the hospital, we were able to have a fiscal engine, an economic engine for our organization that responded to those communities, and those communities did not lose their healthcare access. Those two communities were in desperate need of mental health and dental services, and so that bringing that into the value of those communities was really important. The next slide is the Capital Link survey. In Missouri, we do this through our Primary Care Association. Every FQHC receives these statements every year. So this is actually for 2018, the data from 2018. And so you'll see the biggest piece is the savings to the system, 16% lower cost for health center Medicaid patients, and a $3 million savings to Medicaid. And where our hospitals and rural health clinics really drive into this information is the savings to the overall health centers. We share a lot of patients with the hospitals and rural health clinics. Going into the conversation from a leadership perspective, that there's enough patients to serve everybody, and if everybody is focusing on the services that they do best, all of us can coexist in one community. The next is just our updated strategic initiatives. The first ones were really, they're ingrained in these as well, but we recently went through an updated strategic planning process. Not a lot of it has changed. We did add development, policy, and advocacy, and that is a space where, as a network, we're really able to spend time learning about our peers. And so staying in tune to the American Hospital Association. We partner with the Missouri Hospital Association, the Missouri Rural Health Clinic Association. So we're not just interested in advocacy for FQHCs and advocacy for networks. We're really looking for those common crossovers to where we can all get on the same page and advocate together. What we're finding is that rural hospitals and rural health clinics don't have the capacity to take on a lot of independent advocacy just because they're so swamped in the day-to-day operations. And so as the CEO of the network and the health center, I feel like that's my obligation to the healthcare system, that I spend time learning about their initiatives and then helping to provide that advocacy support at the state, federal, and local level. Lean operations, again, is I go back to the fiscal piece because there's some misconception about how FQHCs receive their funding and the restrictions and those type of things. But we've had to be lean from the beginning, because in the beginning we had no resources, and so building all of that from the ground up, I do think makes us more appreciative of the dollars that come in. One of the things that we were able to do, I think COVID has given us a platform to be really helpful to the critical access hospitals and the rural health clinics. They were unable to do COVID testing because of the restrictions within their own organization, and then supply chain issues. And so we took over all of the COVID testing responsibilities in our region to help keep that legwork off of the hospitals. We also worked with our metropolitan hospitals to make sure that if somebody did need to be hospitalized, we were able to transport them directly to a hospital that was accepting COVID patients and not taxing our local EMS officers with transferring from the local emergency department all the way up into the city. And so kind of taking the lead on some of that, I think, was really helpful for our hospital partners. The other thing is that we've been working really hard to make sure that our nurse line, our 24-hour nurse line, is operated by local staff. We typically use an after-hours company, but since the COVID pandemic started, and we continue to monitor those lines 24/7, makes a huge difference for our patients and in the community to know that they're going to talk to a nurse that's employed locally. Our hospitals and rural health clinics appreciate that because they can trust that information is local and it's not boilerplate. And then strong communications. I think we're going to talk in a minute about some impact potential between partnerships of FQHCs, rural health clinics, and critical access hospitals, but really being open and transparent and honest about what's going on, sharing roles and responsibilities has been super successful for us. We actually share a physician with our local hospital and rural health clinic. He does nurse practitioner oversight. He also is able to help us do ER. He also works in the emergency department, so he does emergency department diversion programs, trying to get people who are seeking primary care in the emergency department to get an appointment next day with the clinics, which he's able to schedule at that visit. The next slide is just the definitions of Safetynet providers and impact potential. And so some of the things, I'm obviously not going to go through all of these, but some of the things that have been really important for us is that emergency department diversion. It took us a long time to figure that out. And we went from as simple as writing standing orders that could be utilized to the place we are now, where there's a shared employee in the emergency room. That one-on-one training and education of the emergency department staff has been very helpful. We also share a nurse, an RN that works the emergency room on the weekends and works in our clinics during the week. That particular nurse is also trained in our opioid addiction and recovery work, which is really important because we can do some induction programs here for Suboxone. The hospital is not as comfortable doing that, and their priority is to get that person admitted into a mental health facility, which beds just currently don't exist in our region. So being able to free up that emergency room space is important. It's also it helps manage stress of the providers, because there are times that somebody could be sitting in the emergency room for days waiting for a mental health bed. And so having a couple of crossover staff has helped us improve that communication. And the peer-to-peer work has been extremely phenomenal as well. They can talk nurse to nurse, physician to physician. We even have our dentist who provides support in the emergency rooms for oral health pain, repeat patients for oral health pain. We guarantee those patients a next day appointment at either 8 a.m. or 1 p.m. And so the hospitals know that they can send a patient just to walk in our clinics and we'll pick them up the next day. The other is the community health needs assessment. FQHCs have to do this, as well as critical access hospitals. They can be expensive to outsource. The information is typically very similar. And so partnering on the community health needs assessment, also lining up our strategic plans is helpful, because we know that we're all working towards the same goals. The other important piece of that is that we can figure out roles and responsibilities. And so knowing that the hospital is handling one critical component of that community health needs assessment. If it's part of their strategic and implementation plan, we have an opportunity to visit with them about ways that we can be helpful, and vice versa. We also partner. OBGYN is obviously a shortage in most rural communities. We have our hospital system, both of them, all three of them actually, don't have an OBGYN on staff. They don't do deliveries. And so getting a plan together to address pregnant women in our community was a priority. We recently hired a midwife who can see patients, and then we collaborate with a larger hospital in Kansas City that they can do the deliveries at, and the oversight. OBGYN can do C-sections and other surgeries that the midwife cannot do. So by bringing that midwife in to our community, it's opened up the access for pregnant women to be seen in the community, as opposed to driving about 45 minutes to the nearest Safetynet hospital for those services. We're also able to focus on some women's wellness programs through different programs through the state, and also try to focus on some prevention strategies for teen pregnancy. Behavioral health contracts. We started out sharing a psychiatrist with the rural health clinic. The rural health clinic had a hard time managing the space needs of that, so we were able to assume the responsibility of that psychiatrist and handle psychiatric needs and therapy, and then refer back to the hospital and rural health clinic for the primary care. So I know that our mentality is not the same as others, but we strongly believe at the board and staff level that it's important that we're all working together to try to meet the needs of the patients. And so we don't try to, steal patients from each other. We try to be in good communication. And if somebody comes from a hospital referral or a rural health clinic referral, we refer them back for the continuation of care. And if we can provide a portion of that, then we feel like that's important. So, excuse me. I took a look at the core competencies of the FLEX program and picked out two that I felt like we could use our model to address some of those core competencies. And so the first is building and sustaining partnerships, and the second is future models of care. As it relates to building and sustaining partnership, I mean, I've talked about that a lot along the way. Some things that on top of those basic things, some things to think about is that due diligence for compliance. And so making sure that if you have a group of health leaders sitting around the table, that there's respect for critical access hospital compliance issues, rural health clinic compliance issues, FQHC compliance issues, et cetera. Many hospitals are JCO accredited. FQHCs go through different accreditation services. And so having respect for those common areas should be where people are spending their time. Also, having community-minded leadership, transparent and honest conversations is critical. And so one of the things that we did to combat some of that was when everybody came to the network meetings around building these partnerships, is we really asked them to bring their expertise in the area that they work in every day, but we wanted them to think about the outcomes through the lens of a community-based solution. And what we found is that was really difficult at first. But what we did find is that for almost every solution we came up with, there was a role for each person in the table to respond to. So opioid is one that I think a lot of people are dealing with right now. We had EMS around the table, the hospital, rural health clinics, the pharmacies, ourselves, and then some community organizations. And Getting multiple sectors trained on Narcan was a priority, and it was something that a lot of people could do. It wasn't just one organization. We worked with the ambulance district that is, some are owned by providers and some are owned by the cities in our area. And we went through different CIT training models. And so connecting different communities with leaders in the opioid space that were available through network services 24/7 was a big win. The hospital was happy to know that there was a local resource for the Suboxone induction programs, knowing that they would be timely, having direct access to our psychiatrist teams that were doing those inductions. So just really building that, what is going to be best for our community. With opioids, it's going to take us several years to see the data reflecting on those programs. I think a lot of it is because the reporting is hard. It's hard for people to admit that they have a problem, and so your pool of patients is always much larger than you think it is. And we also really wanted to stay away from duplication of services and focus on appropriate place of care. This wasn't a socioeconomic conversation. This is a capacity conversation. So if the FQHC has a psychiatrist and the rural health clinic has a social worker, how do those two individuals and their supporting teams work together to make sure that no matter what point of entry into the healthcare system a patient makes, that we're touching base with each other and making sure that we can do what's best for the patient. Transportation was another huge piece, and we're still battling it. I think, like a lot of communities, we've addressed some pieces, but there's still really big gaps. But one of the biggest pieces that we were faced with was the hospital having to use their ambulances to take people home from the emergency room because they had no transportation. And so partnering with our volunteer driver program, they're able to call us, and we have secured funding to do rides home, discharge ride home planning and implementation from the hospital. And so their care coordinators appreciate that because it's one less thing off of them. We also partner on discharge planning for people that do not have a primary care provider, or if they are uninsured and not compliant in seeking care. We spend a lot of time on diabetic patients. We try to help to reduce the readmittance of that. Hypertension, any type of chronic disease. The discharge nurses at the hospital work in tandem with our staff to follow up on for discharge planning for people that are really in that gap. And then governing body participation. We knew that it was important to focus on having a diverse governing body, and knowing that we were a vertically integrated network gave us some really creative space to do. And so it's not like we're a network of hospitals, we're a network of FQHCs. We are a vertically integrated network that own and operate FQHCs. And so our hospital CEO has a lot of stake in the success of the FQHC because he sits on the board for the organization. Community Mental Health Center, again, they sit on our board for the FQHC, and vice versa. I serve on a lot of their leadership committees, and so we're constantly talking about how to solve problems at that local level. Like I mentioned earlier, COVID is a great way to start these conversations. Some of your providers in your states have less access to testing and treatment. Some have more. And so figuring out how to get them around the table to solve those problems is a really great conversation starter for collaboration. This is just a couple more graphics. And the reason I shared these on here is the first one is our wellness outreach day that we had this last June. We did our level best to make sure that even during COVID, we were getting out there appropriately covered with PPE, handing out hand sanitizer, giving away masks. We worked with our local churches in town. They did a lot of homemade mask making. We brought in the mammogram van because we knew the hospital had reached out and there was a lot of people showing up at the hospital who needed to get in for a mammogram, but their sonogram systems were down. They were not taking patients at the time. And then also getting continuing to address oral health emergencies. So while we had and continue to have no aerosol services for hygiene, we are able to address emergencies. This also got our staff out in front of people to talk about COVID, to talk about the realities of COVID. Like many of you, there was so much misinformation being driven by different social media outlets, et cetera, in the beginning that people were in just terrible fear. And so putting our staff out there, having our board out there, I greeted cars as people came in, and just, I think knowing that they could call and talk to somebody was important. It also helped take some stress off of the hospital side as well. We also did voter registration at that event, which was important because our area in our part of Missouri, we had a lot of people that were not registered to vote. And then we also did a piece on Missouri Medicaid expansion, as well as blood donations, because there was a blood shortage and continues to be a blood shortage. The figure 6 is from a document I'm going to share with you here in a minute, and it just talks about the succession of the development of the network. This was through July of 2018. And then the exhibit 2 is just kind of a breakdown of how we measure our key performance indicators. And how we promote our outcome measures and our outcomes to not only our partners, but also the communities that we serve and our funding partners as well. Future models of care is the other area that the Flex program is focused on. And this is where I think networks can be really helpful. I think that they can try new things. I think that health networks can take some risk where others might not be as comfortable with that. And so here's just some examples. Engaged partnerships, collective strategy, managing expectations. I'll speak a little bit to managing expectations again with COVID. Our counties did not have, they had emergency response programs in place. However, they had to be dusted off. They were dated. And so like many of you, we were so reactive in the beginning. And so managing expectations of who's going to do what, who's going to be responsible for what, who's going to step up and be in that leadership space became a quick crisis in rural communities. We had county commissioners, mayors, city officials that were trying to lead in a healthcare space that was just not necessarily appropriate. The same as you wouldn't want a healthcare leader figuring out how to run a county government potentially. And so we had this complete chaos, and we went through a phase where there was a lot of finger pointing about who should be doing what and who wasn't doing what. And I think one of the responses that we did that was really positive is we brought everybody in. We actually sat in a parking lot of one of our community centers, and not even sat, we stood. in a great big circle so people could be spaced out, and just kind of aired out the frustrations and then came up with a plan. And what that plan did was it allowed us to do a reflection on what had happened so far and to look forward to what we needed to do to respond specifically to COVID. We then made a commitment to getting together next spring and taking a look at COVID as a whole up to that point and how we could duplicate those responses moving forward. The network is going to take the lead on that because we have the capacity at a staff level and can seek out some grants that would bring on some consultants that could work with a vertically integrated network to get those plans ready to go. The other thing we focused on was making sure that those plans were super easy to read. There's emergency response plans that are 150 pages long, and in an emergency, you just don't have time to become an expert in all of those areas. And so figuring out which organization was going to carry which load was really important. Monitoring that progress and performance and that shared workforce has just become really critical. Shared workforce helps us not only with our communication strategies and awareness of what's happening in our communities, but it's also builds much better peer teams across the communities that we serve. And so getting our physicians together and nurse practitioners together across the network, regardless of the employer, and figuring out if a hospital's short on nurses, do we have some that we can send over? When the hospital has a patient that comes into the ER and is an overdose patient, who's the person that they reach out to, and where can they get that immediate help? And is there a way to put that person in the emergency room during those high volume times? HRSA has a rural collaboration guide that is posted. I put the link below, and I can also send that to, I guess, Caleb or Andrew if they want to send that out. But this is we were a participant in this. There was 2 organizations that were selected by HRSA and the National Association of Community Health Centers that focused on collaborative care that involved hospitals, rural health clinics, and FQHCs. The other organization is run by a hospital administrator who he's the hospital administrator and the administrator for the FQHC. They have a phenomenal story in here, and I would really encourage people to download that and take a look at it. A lot of work went into it. But I liked this quote. This was from, this was from the CEO of one of our healthcare organizations, not the CEO who contributed the clinics, but his successor. And he said, "Needs were varied. We knew none of us could do it all. And if we didn't come together, there'd be unmet need. We knew it wasn't always going to be fair. It wasn't going to be like going out to dinner and splitting the bill 6 ways down to the penny. That's not the kind of relationship that was going to be successful." It's one of our founding members. And I really like that splitting the bill 6 ways down to the penny, because I think a lot of communities want to say, well, I'm not going to participate because that's not fair. That's not fair. That's not fair. And I think you have to look at it as a collective project. Is it ever going to be split 6 ways down to the penny, fair every single time? No. But if you're always worried about whether or not you got the most benefit out of the relationship, then it's always going to be unbalanced. What we found, here comes another train, I'm sorry. Once we found that we could celebrate those wins together, it didn't become a win for one organization, it became a win for the community. And when multiple provider organizations could celebrate that together, everybody was much happier. This is a figure that's out of the collaboration and coordination guide, and I snipped it to put on here because it's a super easy flow chart for where to get started. I think a lot of times leaders they have the ambition and they have the desire to get their community going in the right direction simultaneously, but they don't really know where to start. And really the first piece is to analyze the environment, and you have to set the platform up for shared leadership during that environment analysis. And so bringing a third party in to manage or to investigate all of your landscape, doing a couple popcorn strategies with different types of leaders, different types of consumers, as part of that process to talk about what's working in our community, what would you like to see in our community, even questions like what would you be willing to pay for. I hate to keep bringing up COVID, but it just gave us such an original crisis to do some direct response programs. And one thing was the rapid test. So we've received rapid tests, we've been giving them, they're getting denied by private insurance. And so we had a conversation with all of our health leaders about, do you want us to continue to offer these? The only way we can do it is to, at the very least, cover our cost, which is $50. The consensus was that, yes, we feel like people would be willing to pay $50 if they needed a rapid test. Reason being, without that result, they may not be able to go to work the next day. Working with employers to make sure that those investments were covered for the employees, if that was an option. So managing those risky conversations, when you're buying $50,000 worth of rapid tests at a time, and you see 3 weeks into it that you're not getting paid on 25 to 30 to 40% of them, you have to make an informed decision. And that was a decision that required multiple layers of our community to contribute. The emergency room is relying heavily on us to do testing. They need rapid tests a lot of times for next day services for somebody, so they can actually provide care as opposed to postponing a procedure again. Again, engaging with potential partners with that community-minded approach is really critical. The collective strategy can be so much fun. You take the analysis of the environment, you determine where the holes are, and then the collective strategy is to figure out what are we going to do to respond to these. And I always tell people, never underestimate the creativity of people sitting around the table, giving people an opportunity to contribute, to speak, because you can come up with some really engaging, really sustainable options for addressing issues in your community. And then review those requirements and seek technical assistance. Of course, there's a lot of consultants out there. There's a lot of organizations like the Center that provides technical assistance. From a leadership perspective, I'm always happy to sit on the phone or on a video call to help people work through problems. And most leaders that have worked through this type of networking it's one of our greatest things is to sit and talk about how to solve problems at the local level. And so don't ever hesitate to reach out to some people who have tried some things that, maybe you just want to learn a little bit more about. And then let's see, I think that brings us to the end. That we are focused on building communities. Our FQHC is called the Live Well Community Health Center. We're very active on Facebook and Twitter. And we're getting there with Instagram, and our YouTube channel gets decent traffic. And then we also just launched a podcast. So I'll be sure and share that podcast with you, Caleb and Andrew, and you guys can utilize those as you wish. But
Yeah, absolutely.
That really is the end of the presentation.
That was great, Tony Ann. I wish more people could hear you, or you could hear more of us clapping. That was great. Does anyone have any questions before I have some? I can't imagine Terry doesn't have any questions.
Hey, Lobon, since you mentioned me, I will ask. First of all, I just wanted to say I've known Tony Ann for, gosh, it's been probably 20 years or so. Just an extraordinary leader. What she has accomplished in that part of Missouri is truly remarkable. I remember talking to her in 2014, and at that time, they were already doing care coordination with the hospitals and clinics. For those of you that have tried to bring FQHCs and rural health clinics and hospitals together, know how incredibly difficult that is. There are so few good models out there. And the other thought is just simply that section of the country has positioned itself to be really very, very successful in the new value payment models, however they come down, whether they're community transformation or ACOs or whatever it is, they've done the groundwork, and that collaboration is just extraordinary. So having said that, Tony Ann, did you get a lot of outside funding to help kick off some of these programs? Just give me some sort of a perspective on that.
We did. So we originally got the funds from the public health, the Missouri State Public Health Office to do our foundation work. We also had 2 foundations in Kansas City that continued to support, but gave us some seed money to write our first strategic plan and help develop some infrastructure. We needed things like bylaw, our bylaw revision and officer training for our board training, those types of things. So we did. One of the things that we've prided ourselves on is when we seek grant dollars, our goal is with grant dollars is to start new programs, responsive programs, and then sustain those. And for the most part, most of our programs have continued. They might look a little bit different because of the things we've learned along the way. We had a diabetes and depression program in 2012. That was really our first care coordination program. And we're still doing that today through different methods, but still targeting that same patient population. So yeah, we did. We try to use that funding to start new initiatives.
Really great. Did you have any, I guess, holdouts to Terry's point about that coming together, and to the extent in which that you've shared with us your guys' effort in that community? It's not easy. Were there some that were a bit more reluctant and joined later, and once they were able to see some of those outcomes, and how was that? I guess were there? So we imagine immediate excitement.
We definitely had some late joiners. We still have some people that we're working on even all these years later that we would like their organization to become more involved. That relationship building is just continuous. We've even had people who, when we take on different projects, say, I don't really have the time to commit to this, and so I'm going to take a step back. We allow a lot of that in and out, depending on what the program is focused on. That flexibility, I think, is valuable to leaders because they want to know that they can kind of pick and choose the areas where they're going to invest their commitment. What we find along the way is that the grassroots growth then that takes place from those initiatives usually will bring different leaders in from those same organizations. So it might not be the CEO, or it might not be the executive vice president of an organization, but it might be a nurse champion or a public health champion or a patient or, you know, somebody who's made great strides in their program alone, and so they want to become more involved. We didn't talk a lot today about our volunteer program, and we do a lot of volunteer recruitment and training as well, and that's where we try to capture a lot of those testimonies and patient stories and try to make sure that we have the consumer voice in a lot of what we do, so we can truly be responsive to their needs.
Yeah, and please, others, I want to encourage others' questions. I have hundreds of questions. I'm really interested in the collaboration efforts and as well as the strategic planning, but I'll give everyone just a second. And please do unmute your microphone to ask questions or utilize the chat box.
I appreciate the comment about the trains.
Yeah, Ronnie.
Sorry.
So I had a question. You referenced strategic planning, and it seemed to be there's a lot of it, and it's almost a continual process of making sure your efforts are directed toward the goals and mission of the organization, and those that they reflect the community's needs as well as the wants of the organization.
Mm-hmm.
How much connection is there between your guys' strategic planning efforts and the hospitals and the other rural health clinics or other providers, as well as other entities in the community? Because you would have different objectives than a hospital would, but a lot of those efforts seem to be aligned.
Right, so we do a very specific piece of strategic planning that is focused on alignment. And we look at, like organizations, we compare our alignment to our funding partners, national partners. I can send that over to you, but it's actually a chart that we use. We line up the initiatives and see if we are on point with where people are trying to send the message or spend their time. We do take it one step further and try to connect with the person at that organization who is leading that charge. So housing is one example I can give. We do a very small housing initiative. We're not HUD, we're not HUD or Section 8, but we work day to day with the HUD and Section 8 organization in our community. And so they told us that one of their gap areas was their ability to give vouchers to people for hotels for up to a week to stay if they needed to wait for their application to be processed or a place for them to move. So we went out and sought some fundraising. We actually did a grassroots fundraiser to put those funds aside. And when the Housing Authority calls us and says, we have this person that needs somewhere to stay, we coordinate that with the hotel. We actually send a community health worker to, if that person needs a ride, pick them up, if not, meet them at the hotel and address any other needs that they might have, such as health issues, social issues. Have they eaten? Do they need some clothing, bedding, that type of thing? So we try to find those areas that are open where those partnering agencies can ask for our help, and then we can work with them going forward. That's
a great program and a great example of something.
Yeah, I'll send that over to you.
I'll take it. Awesome. Yeah, that's great. What other questions do we have for Tony Ann? I want to make sure we provide ample time for questions. We have some polling questions still, but I want to make sure we take full advantage of Tony Ann's experience while we have her. So as most of our audience is flex coordinators, so they work primarily with the critical access hospitals, and they do encourage this type of collaboration, be it from the hospital or from, you know, whomever is spearheading it. what, just if we were in an elevator and I said, hey, I want to do this in my hospital, in my community where I live, and I'm the CEO of the hospital, what would you say would be your tip or your suggestion, or how do I get started? I'm new and I don't have any relationship with the RHC or the FQ in the community.
I would start, well, if you didn't have any relationships, I would definitely take a look at your community health needs assessment and see what services are available in your community. And if there is an FQHC or an RHC, it can be as simple as working through your local public health department to make an introduction. Check with your staff. In rural communities, everybody knows everybody, it seems like, no matter if you're a big rural community or a small rural community. Check with your leadership team and see who they know that can help make that friendly introduction. And if there's not a connection there, I would just pick up the phone and say, hey, I'm interested in partnering with you. I'm interested in helping meet the needs of our community. Can we sit down and talk? And at that meeting, I would bring up those community health needs assessment areas.
That's great advice. Thank you. Any questions for Tony Ann?
I really appreciate the opportunity to speak.
Yeah, we really, really do appreciate having you. It's a great opportunity here, like I said, from boots on the ground. Successes as well. It's nice.
Yeah.
All right. Well, while we would let others think about some of the questions they have, I'll ask Andy to put the exit polling questions up. What are some surprising, I guess, efforts that I think the housing one is really neat too, but what are some of the more surprising community needs that you guys have been able to see, maybe that you've addressed and maybe that you've not, but like, oh, I never would have thought of that.
Some of it has been really small. Like we found through some conversations with Children's Division that a lot of families are separated because the parents or grandparents don't have a bed for the children to sleep in. And so we started a mattress program where we work with a hotel chain. They donate their mattresses. They have to flip them. I think it's every 2 or 3 years. They donate those to us, and we work directly with Children's Division and Family Support Division to help keep families together. Some other things that we do is we do a program called Project Connect, and that program came out of a significant increase of adult dental emergency needs that we were seeing at the emergency room. So 4 times a year, we take our dental unit and we work in the communities and do free extractions for adults that have dental pain. They don't need a referral. We bring as many of our dental team that can come. The only kind of drawback is that we don't carry gas on our dental unit, so everything is local. But a lot of times with that much pain, the tooth is ready to come out anyway. They walk away with a couple days of antibiotic and a follow-up visit for that. We've had times where the line has been too long for us to get through it. We guarantee that service to everybody who showed up that day, so we hand out vouchers, and then we connect them with a community health worker if they need a ride to the visit. And then our community health workers follow up with them after that. The other thing we're getting ready to do is Missouri just now did Medicaid expansion, and we've been spending a lot of time talking about how to reach people. And so we're going to actually be going back 18 months and having our community health workers reach out to all of our uninsured patients in the system and see if they would like to set up a one-on-one meeting
Consultation.
with our community health workers to see what programs they would be eligible for enrollment. We're hoping that face-to-face touch will also focus on, you know, their family needs and what else that they need from the healthcare system.
Yeah, and the uninsured population is one of higher need. So they might, if it's 18 months, they might need another appointment. So
Right.
it's another touch, just another touch. Hey, reaching out.
Yep.
Again, is really great.
Yep.
Yeah, again, there's so many things I want to know. Like, okay, so how have the ER visits, have they declined from the need of, you know, nobody's going in there for dental pain?
Right.
And I think that it does reference one of the concerns of hospital CEOs of, yeah, but I really do, I need some of those patients in my hospital because I
Right.
do financially rely on to whatever extent those patients. So, you know, there is some of that, and that quote from that CEO or board member was really neat.
Yeah, they were really helpful. And continue to be. I think, you know, one thing about emergency rooms that we all know is that their costs are static. And so making sure that we don't take away business from the ER. And so, yes, we've addressed some of we've made an impact on some of the decline on the dental side. We're still a long way from addressing people seeking primary care in the ER. You know, EMTALA requires that they be taken care of because the expenses of running an ER are static. They you know, believe they want to see as much of the patient as they can. They want to get that addressed. And so balancing that risk, you know, of not turning people away from the ER, but then scheduling the follow-up has really been a place that I think we can make a much better footprint, you know, following up on people that were in the ER for a primary care need.
Right.
We still have a long ways to go for that.
Okay. And like you said, making that appointment from the ER when, okay, we're good to go here, but you do need a follow-up for primary care. And here's an appointment tomorrow afternoon or whatever that is.
Right.
So those are great examples.
Yeah.
Church follow-up appointments too.
Yeah.
If you do get admitted to the hospital. All right, guys. Well, I really do appreciate your time and your energy on this, Tony. And we will we'll email back and forth. If you could send me that list of things that you sent.
Yep, I wrote them down.
I would really appreciate it. We'll get those sent out to everyone, as Andy said, in around 5 days to get the recording finished. And we'll let you guys know when that's done and ready. And there's a bunch of comments too that are really just praise. So I don't want to, you know, miss those. So thank you for the great presentation. Thank you for sharing.
You bet. You bet.
Very
Thanks for having
informative,
me.
lots of food for thought. So thank you very much, Tony Ann. Any last questions before we take off for the day? All right, hearing none, I will encourage everyone to go to our website to look at our events page to let you know what next event to participate in. And please let us know if you have any questions at task@ruralcenter.org. Thank you again, Tony Ann. Bye, guys.